in because they feel that they're part of it. And from that, we actually had a patient come to us with an issue that we looked at, and we got the leads of that area around the table, and we sat with the patient and the clinical leads, and they decided actually there is a problem here, and we're now running an audit on that to see what the outcome will be. So there is good outcomes in that, and I think we should be encouraging that. And we would be happy to run clinical audit sessions, training sessions for patients if you decide that that's the way you want to go. Martin, thank you. This is my rabbit, and this is my nephew. Every time you see that, that's my nephew and my rabbit. So
we all have a nephew like that. We know it's your rabbit, really.
It is mine, a rabbit.
Yeah.
It's all mine. I think we'll break for coffee.
You want to do now?
Just before you.
Yeah, that's fine.
Is that all right? We'll break for coffee. And we can.
At the moment I work with Martin, but as from next week, obviously I'm going to be on my own in, hopefully not a sinking ship, but we'll hopefully try to keep things going. So I've got a couple of things I want to just cover this afternoon with you. The first one I'm going to talk to you about is the quality standards and the work that we've been doing in Sheffield to try and coordinate it and pull it together and help our providers give us the information that we actually need. I'm not going to give you too much background and context because obviously we've heard Chris this morning, who was, after all, from NICE, and he knows everything there is to know about these quality standards. But just really the key papers that focus on the quality standards and now they've come about. What the NICE quality standards actually are, the perspective both from the commissioner and the provider. I'll give you a few slide shots of the database that we've been developing within NHS Sheffield and also look at some of the benefits. So certainly from, it's applicable to the NHS in England, as you've all heard obviously, but the quality standards were first actually mentioned by Lord Darcy in 2008 as something that, you know, we would be looking to develop independent quality standards through NICE. Obviously when we got the new government in, that could all have changed, but luckily they went with it, so it's something that's going to be continuing through there. But obviously they're going to build on that and think about the commissioning aspect of care as well, but also thinking about the care standards in the context of payment systems. As a result of that July White Paper, we've now got the NHS Outcomes Framework. So this has got 5 domains within it, and within each domain, the quality standards are actually mentioned and built into that. So it's giving it more and more impetus, really. So now it's saying as well that the NHS Commissioning Board will commission NICE to develop the quality standards, which set out evidence-based criteria and standards across the whole pathway. So again, it's changing the focus, looking at commissioning, but looking at the whole pathway, as we've heard more about this today as well. Certainly in terms of a regional perspective on this, our Strategic Health Authority for Yorkshire and Humber also produced a quality improvement plan which will last until their demise in 2012. This also brings into play the quality standards, and as Martin mentioned earlier, that they actually build on that we need a populated dashboard within 6 months of issue, and we also need 100% compliance within 2 years. So building on that locally within NHS Sheffield, we decided to do something about it. Again, it's being proactive rather than reactive, being told that we will need to do something, and work with our providers then, linking it into our contracts and also into our quality schedule, so it makes it official that our providers then have got to do something about it. In terms of the quality standards then, this is the quote that NICE actually gave, and again Chris broke it down this morning, so it's just covering ground that we actually talked about this morning. But they are markers of high quality, cost effective patient care. And interesting, NICE also state that these standards are not requirements or targets, but the care system is obliged to take notice of them. So although they're not mandatory, like for example the technology appraisals are, there are things that we've got to put in place, and obviously when you look at the volume of the standards that are going to be produced within the next 5 years, we've got to start doing something about it and addressing some of the problems that we're going to potentially have. In terms of the process for developing the quality standards, at the moment the National Quality Board actually discuss and decide and agree which topics are going to be selected. I think that they're hoping to work on the assumption that we've got some existing guidance or evidence available, and I think the one where they've struggled has been the neonatal one, because there was quite a severe lack of evidence compared to some of the other disease areas that they've looked at. So I think in a way it's going to help, because it'll start to identify where potentially we've got a lack of research or evidence to support what we should be doing, and also then kickstart the research programme. But it's also going to help us build on and bring together the areas of quality and care evidence that we do already have. There's quite a long development and piloting process. Whether that will change as NICE pick up speed and actually gather momentum with this programme. But as in all pieces of guidance that NICE actually develop, there is a hefty manual that incorporates everything that they go through, so that it is done with stakeholders, it is done in conjunction with other providers around the country. At the moment, I think anyone can actually be involved in the consultation and piloting process, as NHS Sheffield have been. But I do feel from the middle of this year, it'll be for stakeholders only, so providers will, or organisations will have to register with NICE to be able to participate in the consultation and development of these standards. And from that process, NICE then develop final statements of quality. It is supposed to be between 5 and 10, but that's already been broken by the chronic kidney disease, which now is 15. So I think it really depends on the type of guidance that's being produced and the amount of evidence that there is to support the whole pathway. So in terms of the existing standards, we've got VTE prevention, stroke, dementia and neonatal care, and the latest one this month was CKD, chronic kidney disease. And again, there's going to be a library of 150 of these within the next 5 years. So in terms of what these statements actually and standards actually look like once they're produced, they're all following a similar format at the moment. We get an introduction and a rationale, and then a table of the statements that make up that standard. For each of those statements then, we get the detail that lies behind them, so you can see exactly where they've come from. The quality measure, they're looking at the structure, process and outcome, and using numerators and denominators now to start and depict the key information that you need out of that. What it means to different audiences, so what it means to patients, commissioners, NHS providers, so it breaks it down so everybody understands fully what it means to them. It clears up the definitions that are given in the standards and the statements, so everybody is collecting exactly the same information in the same way. And it also gives the data source, and I say mostly from clinical audit, but where there's been a national clinical audit or some other NICE guidance, then it can be pulled from that as well. Alongside all of this, NICE also provide implementation support, so patient information that they produce. For the quality standards, they produce cost impact and commissioning assessments now, so commissioners can start to break down the specific statements within that and look at the implications for them and what it means in terms of commissioning. There are also slide sets and audit advice available, as with the other clinical guidelines and guidance from NICE as well, so you've got the whole suite of implementation support there for you as well. In terms of our perspective on this, from a commissioner perspective, we are going to make it integral to our commissioning, our contracting process. Although they aren't mandatory, NICE are making the assumption that we're building on best practice, and it's usually built around guidance that should already have been implemented. So it shouldn't be anything new to organisations. We've got our quality schedule, so we're promoting consistency in reporting from our providers. And we also report, as Martin has alluded to, from our providers. This will be on a quarterly basis, but hopefully through it being automated, it's not going to put any more undue pressure on our providers. And the quality standards will also be discussed at our clinical quality review group meetings as well, which are held regularly between our contractors and our providers. We've also got internal reporting and assurance, so building on the process that Martin described earlier, it will be filtered back up to board if there are any problems or issues that need to be sorted out. From a provider's perspective then, it does help them to demonstrate good quality and adherence to best practice, because if this information is ultimately going to end up in the patient domain, so patients can actually start looking at whether the hospital is actually adhering to best practice, then this will make them more accountable to the patient. Obviously it's going to link into payments, so that is going to be a big bonus really for the provider. And it promotes collaborative work with other providers across pathways. Because what we're saying is, because it does work along pathways now, the statements within each standard are going to be applicable to more than one organisation. So it's going to help our collaborative working. But as you can imagine, 150 of these coming down, each with 10 or 15 statements within them, it could potentially create a whole new industry for reporting and monitoring, which we don't necessarily want to do. So in terms of us deciding to address this and be sort of proactive rather than reactive, we need to fulfil our reporting obligation to our Strategic Health Authority. So while they're saying you will need to get your providers to report compliance within 2 years, then we need to fulfil our reporting obligation to them. It's helping our providers to report consistently on the quality standards. Hopefully it will help to minimise reporting, so we're not creating a whole new industry, we're building on the things that are already there, and we wanted to use innovative IT solutions, which is something else that was alluded to earlier this morning as well. So in terms of what we've actually done in NHS Sheffield then, in terms of our requirements, we needed something that will be web-based, because if we're saying it needs to be freely available really to our providers, who simultaneously will be entering their own information and data into this system, it needed to be web-based. So we've actually built it. It's based on Oracle, which is a free database type web tool that's freely available. So we decided to use that technology to build this web tool up from. Obviously it's got to be user-friendly, so it should be intuitive. Any provider looking at it should know exactly where to go, what to do, how to use it. There should be some ownership as well by participating organisations, and what we did while we were actually developing this database and this web tool is actually involve our providers, so we didn't do it in isolation and say, there you are, that's a tool you should be using. We actually involved them and got their nice leads involved with us and to actively use it and pilot it and then provide us with some feedback. So what we've actually ended up with, it's not a finished product by any means, but what we've finished up with is something that, you know, people can actually use, and it will continue to develop as we go through the process. We've got 4 levels of access defined within the web tool. Me, as an NHS commissioning body, if you like, I'm going to be the super user. So basically, because we've agreed to use this over our healthcare community, I will be able to see everybody's records, have access to them, give read and write access to anybody. So you've got, it gives you a whole new level of access to the actual data. When we move into trust admin level, that will be the nice appointed leads within each organisation. They will then have responsibility for their own records and giving access to other users within their trust. When it comes down to subject admin, that's when the trust admin person can actually give access to specific clinicians or managers or people who need to maybe input some information or evidence into particular records. So again, it's sort of counting down the sort of levels that people have got access to. And obviously view only then, so you can't actually amend anything within the web tool or the database, but you can actually view the data for your organisation. We did have an issue crop up this week where one particular trust admin person was saying, you know, we don't want other trusts to have access or be able to view our data. That's not the case. It's only the super user who can actually see all of the data. You can only see the trust admin people and lower down can only actually see the data from their own organisation unless they agree between themselves to share and give other people view access. So there is that limitation on it. And because we've got such good reporting systems within Sheffield, we needed something that would fit with that reporting system. So we have built that brag rating system and reporting system into the web tool as well. It has changed again since we actually put these slides together. It does look now a lot easier to use. We've got separate tabs across there. So where you've got home, title, statement, action and reports, they're all now separate tabs. But it looks virtually the same in every other way. So we've called it the Nice Quality Standards Recorder. But it's really from NHS Sheffield because NICE haven't actually endorsed this web tool. We couldn't actually call it the NICE Recorder.